So I was wondering if you could tell us first about how you first became interested in pursuing a career in medicine.
Oh, that's easy to answer. I always wanted to become a doctor at the age of 4 or 5. At the age of 6, I was interested in dissecting animals and exenterating ducks and geese. And I was very much interested, very much from the beginning. And during World War II, my entire school was moved outside from Munich. I became a medic and was trained by the German army at the age of 14, and I worked in a German hospital for a while, passed the exam, and I became a designated medic for my classmates in the school. So at the age of 14, I trained my first abscess, and I took care of medical problems during World War II because there were no physicians south of Munich.
Did you see any soldiers that were injured?
Yes, I did see soldiers quite a bit while I was working in the army hospital. On one day we had a whole train arrive for this particular hospital with 1,000 wounded soldiers from the Russian front. Also on one day, I was 14, the physician on duty asked me to come up into the operating room when a patient was in a lateral position, and I saw that they were taking a metal rod and opening the area over the trochanter and hammering the rod into the femur, which apparently was one of the very first intramedullary nailings in Germany in 1944. They were done on British pilots, and then the x-rays were taken afterwards and then were sent via Switzerland to Great Britain. So I was the witness of one of the very first Kinchner, the name is Kinchner, intramedullary nailings in 44.
How old were you at that time?
14.
14 years old.
And I jumped a grade in high school so I could enter medical school in Würzburg at the age of 18. And we had a 10-semester program, 5 years, and my father always sent me to hospitals, first as an orderly and then as an extern. And so I spent all my time on surgical wards, and I did 12 appendectomies before I finished medical school, and I was an MD at the age of 23.
Wow. So where did you attend medical school?
First in Würzburg for 5 semesters. Würzburg was totally destroyed. We were literally hanging off the rafters just to go to classes, and then my clinical 5 semesters I spent in Munich, and then did my dissertation, which was quite a bit of a job for about a year and a half, and I finished that. And so I was a fully christened physician at the age of 23.
So how did you wind up in USA?
My mother thought I should have a good time and I should go to America for a year. And I applied to the Hilton S. Reed Foundation in New Jersey. Dr. Reed was an internist in Ocean City, New Jersey, who felt that there should be an improvement in brotherhood and understanding between the two countries, namely the US and Germany. And so he would come to Germany and would look for maybe 50, 60, 70 young German physicians and bring them over to regular community hospitals, one of which was Memorial Hospital here in Worcester. Most of them were in New Jersey. And after I was interviewed by Hilton Reed's associate, I came to Elizabeth General Hospital in New Jersey in 1954. Had a rotating internship for 13 months. I have to admit, most of my time in pediatrics and internal medicine I spent in the operating room in the afternoon, because there was a cancer group, the Green Group. They were trained at Roosevelt in New York, and I loved to scrub for them. They were superb technicians. While I was in Germany, the chair of the Department of OB/GYN wanted me to come back as one of his residents for residency for about 8, 9 years. And I told the surgeons in New Jersey, and they said, Utzschneider, don't bother with OB/GYN, you're going to be bored. You've got to go into general surgery. And this is what I did. So then after I finished my internship, during the internship I fell in love and I married an American nurse here. And so we went back to Germany because by contract we had to go back for a year. And then I applied to about 94 different residencies, one of which was a community hospital, which was St. Vincent Hospital here in Worcester. And I felt I should spend a year at a community hospital in Worcester here. St. Vincent Hospital at that time was a 600-bed institution, brand new. And so I stayed the first year and then the second year, and then the surgeon from the Fallon Clinic came, which was a very small group practice, and asked me whether I was willing to join them, and he was willing to wait for me another 2 years. So I finished my third year, my fourth year, and then had to get a license in Massachusetts, which is a separate story, and as a foreigner. And so I joined Fallon Clinic in 1960 when there were 5 members, Doctors Brosnan, Myers, Fletcher, Massarelli, and Manning. Manning was the surgeon who was trained by the people at the Mayo Clinic. Fletcher came from the Mayo Clinic and Massarelli came from the Mayo Clinic.
So you did your residency in the United States?
At St. Vincent Hospital, from 56 to 60.
So you attended medical school over in Germany,
Mm-hmm.
and then your internship year, did you do that?
Yes, Elizabeth General Hospital in New Jersey, and then 4 years here.
Okay.
And then I had to pass my boards here, obviously.
In Germany, do you have to pay for medical school? Or
Yes, yes, but it's very inexpensive.
Do you remember approximately how much?
Oh, maybe the equivalent maybe of $100 per semester.
And how do you think that compares to today's cost of medical education?
That's an entire different ballgame. You cannot, make an overall statement because all the universities in Germany are state universities. And so it really doesn't make a difference in Germany whether you go to the University of Berlin or to Munich, Hamburg, Heidelberg. It doesn't make any difference, has no implication whatsoever after you've finished. The other thing is what people don't know is that in this country, after your medical school, you have your residency for 5 years or 6 years or maybe a fellowship, and then you basically are being kicked out into the real world. So after 8 years after you having finished medical school, you have to face reality. Whereas in Germany, when you finish medical school, then a very long slog of years starts to become a resident, and that can go on for 5 years, 10 years, or 15 years. And most of the residents really never make it because if, for example, in surgery, you just cannot go out and say, well, I'm going to hang out my shingle, I want to be a surgeon in Munich. What you really have to do is you have to stay within the hospital framework and wait until there's an opening for a chairman of a hospital. And so rural hospitals, for example, the hospital in Garmisch, Partenkirchen, where the Winter Olympics were in 1936, when there was an opening for a surgeon, there were 70 applicants, of which I think 40 were professors of medical schools. So when you say, well, it's so inexpensive, but then you have that huge spread of years where you are a resident ad nauseam forever. And as you probably know, there are physicians in Germany as of this moment who are unemployed, who work as cab drivers.
So it seems like there's definitely no shortage of physicians in Germany
No.
right now or in the past?
No, none at all. Nobody wants to go into the hinterlands, but there's a real hierarchy of the universities and the medical schools, and they control who will become the chief of surgery at a small hospital. There are no hospitals where you can say, well, I'm going to get 5 beds or 10 beds, so-called lay-in hospitals. They don't have that. So it's hard to compare.
So you mentioned earlier that someone took you aside and said that you wouldn't enjoy OBGYN.
Right.
Is that one of the main things that influenced you to go into surgery, or were there other things that led you along that path?
I think OB/GYN obviously has two components. One is OB and one is GYN. In OB, you deliver children and you do C-sections, and that type of surgery is always the same. When it comes to surgery, in the 40s and 50s, I really feel that the majority of gynecologists at that time were not trained in superb surgical technique. And the big guns in American gynecology were former trained general surgeons, i.e. Dr. Parson, Dr. Ulfelder, and I could enumerate a large number. And when you look at the surgery in GYN, you have surgery of the cervix, and the ultimate obviously is a Wertheim resection, which is an extended abdominal hysterectomy, cum. One step higher is an exenteration. And otherwise it's vaginal work and a lot of work on tubes and ovaries. And unless you get into exenterations and radical surgery, I think it's very easy surgery. There's really nothing to it. Whereas I think in general surgery, especially in the 50s and 60s, the spectrum was so much broader. Especially on a place like St. Vincent Hospital, our residency training involved a rotation through 2 months of urology, 2 months of orthopedics, and then 1 or 2 electives, and then 6 months of general surgery. And we did this year after year after year. And I'm a very strong believer that you are such a better GYN surgeon if you have done work on the ureters and on the bowel. Whereas when you look at the OB/GYN training, it was 3 years. I believe now it's 4 years. And if you take from those 4 years, a year and a half into obstetrics, how can you train a gynecologist in 2 years? All the surgical expertise, the general surgeons have to spend 4, 5, and 6 years. And that was one of the main reasons I felt it was better for me, and I thought I could do more good to my patients being a general surgeon.
So you always knew that you wanted to do some sort of surgical specialty as opposed to medicine?
I wanted to be a surgeon who technically was very good, but also had an interest in medicine. I felt a good surgeon is an internist who also has technical expertise. And I thought I was right over the years in the 60s and 70s. For example, treatment of cancer in the 60s was a domain of the general surgeon. We trained all our residents, and I was trained how to take care of cancer of the breast, or how to take care of cancer of the stomach, cancer of the colon, cancer of the head and neck, etc. We were trained this way. And so I thought this would be a good thing to do. And then I was very fortunate because in 1958, 60, suddenly vascular surgery came down from heaven. And so I was on the ground floor, so I became very much interested also in vascular surgery. And nobody had training at that time. There were no residencies, no fellowships, nothing. There was this one gentleman from Texas who would write articles, and we didn't believe his articles, and his name was Mike DeBakey. And so then locally, some of us started to do vascular work and did a couple of firsts for within the city. And it was a very, very exciting time. Plus, my training was influenced quite a bit by a surgeon and from New York, from St. Luke's, Dr. John Madden, who wrote the textbook on surgery, the Atlas, John Madden. And he came up, and at that time we also at St. Vincent, we had an affiliation with Georgetown. And so the Georgetown medical school surgeons would come up, and internists and urologists. And so we really were taught quite a bit, a broad spectrum. So at the end, I wasn't afraid to do a radical hysterectomy. I wasn't afraid doing an exenteration. I wasn't afraid going into the neck and doing a radical neck dissection, or in fact, I think the first commando done was here in 1959. You know what a commando? As the Pope of head and neck surgery was Hayes Martin in New York, who wrote the textbook on head and neck surgery. And commando operation, I think, was introduced to this country around 42, which is a combined resection of the floor of the mouth, 2/3 of the tongue, resection of the mandible with a unilateral neck dissection, and trying to reconstruct it together for a cancer of the tongue or a cancer of the buccal mucosa, mostly cancer of the tongue. And we were trained, and I was very lucky, and it worked out well.
So you wound up practicing at the Fallon Clinic?
Yes.
And did you stay there your entire career, or did you move around?
No, I didn't move around. I stayed with Fallon Clinic for 22 years, and then we had a separation. And I started to practice on my own in 1982. And I remained at St. Vincent, but I also opened up an office in Clinton, which was a small community hospital. But my most productive years were at St. Vincent Hospital, and I became very involved in managing acutely ill patients. We started an intensive care unit, and I was made director of the intensive care unit. Then I became involved with this concept of critical care medicine, which started in Pittsburgh. There was the Society of Critical Care Medicine, and I suddenly realized there's more to it than just doing surgery, that you had to combine, it's a team approach, and we had an exhibit at the AMA and at the college meeting on the team approach for the critically ill patient, which resulted then in us looking for an intensivist and to develop a department of critical care medicine, which was the very first in Massachusetts, not in Massachusetts, here in Worcester. The medical school didn't have one, but we had it over there. And so these were very, very exciting years. And you know, when you start out and electrolytes are something new, and everybody on the staff has to learn electrolytes, and then the next step is blood gases, and everybody knew what blood gases were. And then somebody comes around from New York and says, well, hyperalimentation really does something, and you say, I don't believe so. Until I realized hyperalimentation has been one of the godsends in surgery. I think it was one of the greatest things. Then how do you do hyperalimentation? Well, you have to get access. How do you get access? Well, you have to puncture the subclavian vein. Nobody had done that in Worcester. And there was an article in the Surgical Clinics of North America from a VA hospital in, I think, in the Midwest. They proposed that you puncture the subclavian vein underneath the clavicle. But it didn't say that you have to lay down the patient. So we started to do that, and that was called for a while the Rudy tube. Because I was the one who was putting in all the subclavian catheters at the hospital. And some people said, that's crazy, until we finally learned the caveats. You got to lay the patient down, or you got to put him in Trendelenburg position, you know, et cetera, et cetera, et cetera. And so I think that was a great, great thing. And that, with the administration of hyperalimentation, having a CBP line in place, we suddenly could say, oh, now we got a CBP, now we can measure CBP. What does that mean? And so then the next step was trying to measure cardiac output. And this was a big deal. And then we suddenly realized vasopressors really don't do that much good. You know, Levovet can be a curse. So it was very exciting, but I should stop here. I could go on for years.
So you stayed in Worcester, the Worcester area, for quite a while then?
Yes, yes. I've been there for 37 years. I practiced for 37 years.
What did you enjoy most about being in this area? Anything in particular?
my work.
Your work? Anything about the community or the individuals, or are you?
You know, I was so busy, and so for 20 years I told my family and my wife, surgery comes first and family comes second. What a fool I was. You know, the kids could go skiing up north, and I liked the shore and I liked the salt water, but this was not it. I was totally committed to St. Vincent Hospital, and you know, the hospitals were combined, and I was very much involved in the development of group practice. And we had many, many enemies,
So could you
including the medical school.
How come the medical school?
I shouldn't say the medical school as much as the District Medical Society. I was just looking through some records, and in 1980, the Medical District Society went on records that they did not like group practice in 1980. And there was a penetration of HMOs for the Commonwealth of 5%, and the penetration of HMOs for Worcester of 10%, and that was horrible. They went publicly. In fact, a letter to the editor was written in 1980. 10% penetration, and you know, what is it now? It's about probably 55, 65%. And group practice is bad. It's bad, bad, bad. And it was hard because when I finished my residency, I had to declare to the chief of surgery that I would join Fallon Clinic. And within 24 hours, I was cut off from any kind of surgery by some of the surgeons for about 6 months because I was joining a group practice in my last year.
And what was the fear of the individual practitioners?
Lose control. Patients would be stolen. So it was a struggle. It was a real struggle. And the only thing we did was in group practice, we really worked. We worked. Because, you know, you don't create something like this out of nothing. I mean, it has to be financed. Where's the money coming from? There were no grants involved or anything of that sort.
Now, were you involved at all with initiating a group practice?
Well, I was treasurer. I was treasurer of Fallon Clinic, and I was doing all the real estate. So I was very much involved.
So would you consider yourself a strong proponent of group practice and the advent of HMOs?
At that time I was. I thought one could deliver a better product. And for about 20 years or so, 20, 25, 30 years. But, you know, something has happened which makes me very sad, which is you cannot measure anymore who is a good doctor or who is not who is an adequate doctor, because really what happens, group practices will try to fish and will try to employ as many physicians as possible. So they don't look at a CV anymore in detail. And so they'll take anyone. Now, whether this is Fallon or any other group practice or even perhaps the medical school, if you take every physician unproven, you're probably lowering the bar. And I had many, many discussions with the president of Fallon Clinic at that time. When you lower the bar, how can you make that physician better afterwards? Aren't you better off if you screen physicians? Theoretically, they are being screened, but I know for a fact if you walk into Worcester now and you are a primary care physician or you're willing to work in the emergency room, you can have a job either at the school or at Fallon Clinic. The other thing which makes me sad is, and I'd always use that parable, if a young cardiologist falls in love with a woman from Worcester, wants to marry her, and he says, I want to hang out a shingle and want to practice cardiology on my own, he cannot do it anymore in Worcester. It's over, it's passé. If he goes to the Midwest, yes, because there's less penetration of HMOs. And you see now ads in the New England Journal where it says HMO penetration less to 5%, or managed care is only 15%. But here in Worcester, you can't do it. So either you're going to be with the school, or you're going to be with Fallon, or you have to join somebody else. And so this allows the discerning patient really to choose. I would like to see a good physician. Whereas in the 50s and 60s, if you were not a very good surgeon, you wouldn't get referrals after a while. Or you would get nailed by the chairman of the Department of Surgery. That's over. That's over. And so I'm very sad about it. So I'm sure one of the questions you're asking me during this interview, the worst things I experienced, and on my way in, I was saying to myself, the worst thing are the lawsuits. The lawsuits just horrible, horrible, horrible. I had 4 lawsuits in 37 years. That's the worst. And the second thing is what I was just referring to, that as a patient, you don't have a choice anymore. You really cannot say, I want to see Dr. Joe Ballantyne because I've heard he's so good. If Ballantyne is with a group practice, then he's going to be automatically a part of this group practice mechanism with all the, and I could give you, verse and chapter of this thing. It's terrible. I'm a patient now with a group practice here. You sit in the waiting room, Rudolph! They don't even say Utzschneider anymore. If you want a lab report, it might take up to 4 weeks. I hadn't been seen by my primary care physician for 7 months. We made an appointment. The next appointment would have been on June 1st, 2002. So do you understand what I'm saying? So really when people are talking about high efficient delivery of healthcare, that's a lot of bunk. It's not. It is not. The bar is lower and it's all about the same, and you really don't know the quality. I shouldn't talk that much.
That's okay.
When I was a resident at St. Vincent in the late 50s, every admission to the hospital, whether it was a general surgical admission or urology or orthopedics, would have a rectal examination or would have a pap smear. And the resident got nailed if he didn't do a pap smear, even on the woman who had a broken humerus. Everybody had a rectal. You don't see that anymore. So, go ahead.
I was just going to kind of continue with that and ask you if you could envision any positive changes that can help solve some of these issues. Or maybe if you have any ideas or ways we can approach the problems that you mentioned.
I think it's going to be extremely difficult because it's a matter of money. It's a money, and it's the consumer, and it's technology. I'm sure you see now on television that the pharmaceutical industry goes directly to consumer. This is the latest osteoarthritis golden silver bullet, and this is the best thing for bad breath. Ask your physician for that new beta blocker. You know, this drives up the cost. That's one thing. The other thing, unfortunately, in the 60s and 70s, the young physicians, downgraded the value of physicians vis-a-vis the patient. I mean, we had battles for close to 20 years because the medical students would come to the hospital in sandals, without socks, unshaven, looking like a hippie from Provincetown. And then they got their backs up. And when you would talk to the school was not very strong initially in helping the attendings in the 3 hospitals, was the City Hospital, Memorial Hospital, because they were so afraid they would lose medical students. And so it was a real problem for at least 10 years to tell a medical student, can't you at least put on a white jacket, or do you have to wear a scrub shirt, and you know, can't you put on some socks and comb your hair, and don't poke your nose when you talk to the patient. And so by doing that, the public developed less respect for the physician than it should be. I mean, the relationship of a physician is not body, I slap your back, isn't it all everything wonderful? Gee, did you have a Budweiser last night? This is not the relationship. There has to be, the relationship has to be at a higher level. And the laying on the hand, you know, some people laugh about it. There is something to it. To leave the patient with a smile on the face, there is something to it. You can't run out and know that the patient still has a few questions. You can't do that. And so that hasn't helped. And so, oh, he's a doctor. You know, I better stop here.
So what sort of advice would you give to a young doctor or a young medical student such as yourself entering into medicine?
Be honest. Be honest with yourself. Be honest with your patients. Don't ever cheat. Don't ever lie. No white lies, and you'll be fine. I've gone through that in terms of, oh, you did an appendectomy last night? Yeah, was it acute? Well, it wasn't that, well, just tell me, was it acute or was it not acute? And I am a very strong believer, especially in surgery, if you once twist the truth to yourself that the appendix really was normal, and you're saying to the attending, it was slightly inflamed, until the path report comes back and it shows a normal appendix, something intellectually happens. You've got to be honest, and I don't know whether you can teach honesty. You can make an effort as an attending, but I think this is the best thing I can tell a young person. And love thy neighbor. That's number 2.
So I want to switch gears drastically.
All right.
And ask you if you could maybe give us an idea of what a typical day was like when you initially started practicing medicine over at Mount.
You mean surgery?
Yeah. Hours.
Oh. In the beginning, I promised the other surgeon that I would make rounds twice a day in the hospital on all patients, all surgical patients. I was on call every other night, every other weekend, or an entire week, 1 week off, and then on the next week and weekend. So I was on call every other weekend. I would see initially surgical patients as well as newcomers who might need a diagnostic workup, and we were only 5 people. And I got involved into teaching quite a bit in the beginning, office hours 3 times a week in the afternoon. I would leave home probably by 7, and I would come home in the average at 7. And after I'd made rounds the second time, and I would go in at least every other Saturday. I had to go in at least every other Sunday, and go in on Sunday afternoon and do my records. So from day 1, it was 60, 70, and then it got worse, 80 hours. 80 hours, 70 hours, 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 80 hours when we started to grow, we took on a third surgeon. We had up to 60 surgical patients in the hospital. 6-0.
3 of you?
Yep. To make rounds on 60 post-operative patients, that's a lot of work. And then I became involved pretty soon in the teaching, and Dr. Wheeler at that time wanted me to become the director of undergraduate and graduate surgical education. So that took time. And then at one point, the house staff at St. Vincent went on strike. They did not want to cover the emergency room anymore. So I had to set up an emergency room corporation and entice attendings to work in the emergency room for a year and a half. So I ran that, which also was work, and obviously, like Thanksgiving, if you're the chief bottle washer, you work on Thanksgiving in the emergency room.
So this was later on in your career, this wasn't at the beginning?
That was probably the mid-60s. And so then I got involved, besides surgery, with the intensive care unit from 4 beds to 8 beds to 13 beds, and ran that for about 6 or 8 years. So it was busy. So basically I was home very, very little. So it really didn't make any difference what was going on in Worcester.
And you mentioned you had a family as well.
Yes, 9 children.
9 children.
Mm-hmm.
Full household.
Superb wife.
Yeah. What was it like for your family, or what do you think it was like for your family to have a busy doctor as a father?
They knew about it. They knew when I was tired, I was maybe angry. They didn't see me very much. They never waited for dinner or anything. I always ate by myself, well, most of the time. And my wife did all the driving and taking them for skiing and whatever, Boy Scouts, Girl Scouts, etc. So I didn't spend much time raising the children.
Did you find that a difficult thing to deal with, or surgery came first, like you said?
Surgery came first.
And were you ever able to take any vacations?
Yep, 2 weeks. 2 weeks a year, and then after about 10 years, 3 weeks. And then I would go to the American College of Surgeons meetings, which were either in Atlantic City or Chicago or San Francisco. And then I became quite involved in my free time and spare time with the finances of Fallon. And that was a killer, because that meant, I know one summer I got up at 4 o'clock every morning and I was in the office at 5 and did conversions of an accounting system an entire summer, and then went to the operating room at 8. I'm not exaggerating. It's
Let's see. Can you think of any technological or pharmaceutical innovations that occurred throughout your career? I'm sure you can think of many, but maybe ones that stand out as being the biggest helpers or changers for you in your practice?
As far as technique is concerned, I think more radical surgery was done in the 60s and the 70s than it's done now. There's just no question about it. We don't do that much radical surgery anymore. So technique-wise, it has become so much easier. And now, in addition to, we have now endoscopic surgery, which is an entire different thing. That's one thing. Really, what I thought changed everything was the addition of blood gases, respiratory support system, measuring CVPs and cardiac output, Starling curve, and then hyperalimentation. I think these were the big, big guns which really made patients survive. Antibiotics, yeah, up to a certain point, but I think it was the pathophysiology. It was Francis Moore's textbook on the metabolic care of the surgical patient, which I think was issued in 54 or 56, which was like this. And this, for the first time, really helped us to overcome the problems. We did a lot of gastrectomies in the beginning for peptic ulcer disease. We did 275 gastrectomies over 5 years at St. Vincent Hospital. I wrote a paper on that one. 275 gastrectomies. We had one stress ulcer bleeding all the time in the intensive care unit, a stress ulcer, because we didn't have H2 blockers. And we knew that the operative mortality for an elective gastrectomy was about 2%, 2.5%. But surgery for a massive GI bleed for a stress ulcer surgery, the mortality was 20%. So talking about changes, the H2 blockers, made a lot of difference. Yeah. It just went like this. Yeah. Staplers were very interesting. I think they raised the niveau and the bar for many surgeons who really did not know that well how to suture. And I'm referring especially for anastomosis between the esophagus and the stomach. So if you do a proximal gastrectomy, even a surgeon who is not super duper trained would have better results. And the same for a low anterior resection, pulls through stapling from below. So the stapler was good in that respect. Whereas people who really know the esophagus, for example, Ellis, Leahy Clinic, they still said they'd rather suture by hand than they would use the stapler. And then as the result of earlier diagnosis, you catch the disease earlier, referring to breast, especially, with mammograms, et cetera, et cetera. And then I don't know whether you want me to touch upon vascular surgery. This was, an entire new field because, we didn't know what to do, in the 50s with a ruptured abdominal aneurysm. The patient just would die. You would not operate. And so just around late 59, 60, just a few major operations became into vogue, even here in Worcester, which was an aortobifemoral bypass, femoral popliteal bypass, either using a graft or a vein, carotid endarterectomy, with or without patch. So this porta cable shunts we were doing at that time, and patients never did very well. And then the routine arteriograms could show us an aneurysm. Initially, we would diagnose them just by palpation. And then how did we drop the mortality of surgery for the aneurysm was by having a CVP line, cardiac output, get your Starling curve up to this point until the patient is tanked up. Then you could clamp the abdominal aorta below the renal arteries and you wouldn't have the problem. And I think the leading light was John Manick at the Brigham, who did 100 consecutive elective replacements of aneurysms with a 0 mortality. So this is an entire, the vascular thing.
Yeah. And you did those surgeries yourself?
Yep. Mm-hmm.
Was that difficult? It's like almost like you're entering uncharted territory.
Yes, it was totally uncharted. There were no textbooks. There were articles by D. Bakey. You would go to a meeting and then you tried it. And then the other interesting thing was there was a thoracic surgeon here, Paul Ware. I don't know whether you're familiar with him. He was trained by Gross at the Children's, and he became involved in closed mitral commissurotomies, where you put a purse string around the atrium, you stick your finger in and you crack the mitral out like this and pull it out. And so then he started with cardiopulmonary bypass in 1958. And we started to do that over at St. Vincent. And so this, for the first time, somebody was trying to bypass patients in 58, but the pump was not a very good one, so that died down until it was resurrected later on. And Ware was a superb surgeon.
Did you see any changes, what patients presented to you with over the years? Were there any changes in the frequencies of different ailments you would see, for instance?
Oh, sure. Well, peptic ulcer disease just flew away. We don't see it anymore. Plus, with the onset of having now gastroenterologists who scope, and with H2 blockers, you know, so that's gone. Large polyps, for example, of the colon, we don't see them anymore. Because of pap smears, you don't see an advanced case of carcinoma of the cervix in GYN. You don't see that anymore. Or an advanced case of cancer of the vulva. Or even cancer of the rectum. You don't see that anymore. So that has changed. Crohn's disease, as far as I'm concerned, has been more or less always the same. Portal hypertension, I don't think we've seen as many as we did in the 50s and 60s. And now with the TIP procedure, you know, you can help the patient much better than if you wait for a vascular surgeon, you know, to do a portacable shunt. Earlier cancer of the breast, obviously, you know, the lumpectomy, plus maybe either axillary lymph node sampling, et cetera, that has changed quite a bit. And that took probably 15 years or 20 years until everybody got on board and said, well, I don't do a radical, you know, mastectomy anymore. You know, I was started out by surgeons telling us the only treatment for peptic ulcer disease for the complications is a subtotal Bilros 2, period.
How things change over the years?
Yeah, you don't do it. Residents, if you do a gastrectomy now, they come in the room and want to see it because they don't know how to do it. The so-called difficult duodenal stump, which sometimes, you know, surgeons were perspiring for 2 hours how to close the duodenum, humble in the old days because nobody knew what to do for it until somebody had that smart idea, putting a catheter in it and create an artificial duodenal fistula. That helped save a few lives.
It's amazing how many things have changed over the years. It seems like the ones that you mentioned that you saw less of later on in your career were all because of preventative measures that were taken before.
I would think so. I would think so.
Colon cancer you mentioned a lot of ones.
Yeah. Now we haven't touched trauma at all. That's a separate issue. You know, resuscitation, et cetera, but. And plus anesthesia. Anesthesia is better than it used to be. Having a cardiac arrest in the operating room now is a very rare occasion, whereas in the old days it would happen. I think the incidence was maybe 1 in 2,000 or 1 in 3,000. So if you do 12,000 cases at a busy hospital, you have 4 cardiac arrests. And, you know, it was a big deal when suddenly everybody would get an EKG monitor on, even for the DNC or for drainage of a perirectal abscess. And first, some of us were saying, what do you need an EKG for? You know, what do you need a monitor for a 5-minute anesthesia? But they were right. They were absolutely right.
Yeah. I had a couple questions in mind.
Please do.
They flew past my head. So you mentioned some of your not so fond memories of how things have changed. Do you have any fond memories or stories that you could share with us?
Happy patients, good results. Where the patient, you know, for years, you know, would write you either a note or send you a box of oranges for something nobody thought, you know, the patient would survive. That's, I know one case where it was a ruptured aneurysm, and we didn't have a ventilator yet. We only had a Bennett valve, and so I designated an orderly to sit at the bedside and open up the valve manually for every respiration for about 36 hours. I'm dead serious. Like this, we did not have that. A patient had lousy lungs, and the guy survived because the orderly was just opening and closing this thing about 18 times a minute. Yeah, this was that was nice. The ruptured aneurysm and the survival, that's very happy patients.
How many of those people could you save normally?
Unruptured?
Yeah.
Ruptured aneurysms? In the old days it was 100%, and now it's about 50%. Yeah. The average 50% aneurysms ruptured. And it has something to do whether the patient is hypotensive at the time of arrival in the ER, et cetera, et cetera, et cetera. And that you don't make it worse when you go in, when you kind of blindly put the clamp down on the aorta, that you don't go too high or accidentally, tear the vena cava or something like that. That can happen. Oh, I've had wonderful memories of patients who were good.
I saw that smirk on your face.
Well, I just remember one was an Arab here at the medical school who had an echinococcus cyst of his liver, and he was in London, and they said he shouldn't worry about it. No, he was in New York. He flew to London, and he had this big, painful thing. And in London, they said, don't worry about it. And so then he kind of flew back, and it ruptured, I think, on his way over before he hit Logan. And so by ambulance, he came here to UMass. And I was asked to take care of him. I had never seen an echinococcus cyst in my life. What to do for him, et cetera, and there was just one thing to do, and take him to surgery and clean it out, et cetera, et cetera. And then I didn't realize he was an Arab from Saudi Arabia, and suddenly all his wives showed up, and and then they were cooking lamb chops, basically. And he was here for about 6 weeks, and he survived. That was good. The other thing, one of my colleagues in 1961 did a cholecystectomy on a patient. And the patient didn't do very well. She had the same symptoms. And so they did a GI series on her, and it didn't show anything. And she still had right upper quadrant pain, so they waited 3 weeks, and she had a second GI series. I didn't show anything, and she still had pains in the right upper quadrant. And so they did a third GI series, and they took the picture a little bit lower, and it showed that she had a mass in the second to third portion of her duodenum, like this, like a golf ball. And the other surgeon said, well, I don't want to reopen it, why don't you do it? And so I operated on her, and this is 1961, and I found a carcinoma of the duodenum. And I'd never seen a Whipple, a radical pancreatic duodenectomy in my life. I had read about it before I took my boards in surgery. And so I was just faced with the thing. So I went ahead and did a radical pancreatic duodenectomy on her. And it took 6 hours, and I hooked it up the way I remembered. And on the second postoperative day, on the first postoperative day, she went hypotensive with a hematocrit of 50, and I brought one of the internists in from Fallon, and he didn't know what it was. And he says, you know what, she looks like a burn. I said, oh. Hematocrit is up, leakage of plasma. So the plasma is where the pancreas was. So I gave her plasma and some blood transfusions. She got out of it. And the lady survived. And after 15 years, She developed a common duct stone between the anastomosis of the common duct and the Roux-en-Y in the jejunum. You know, this is the craziest things. I went back in and took the stone out, and she was fine. So this was my first Whipple, or this was the first Whipple, at least at St. Vincent. And it was 1961. So that was gratifying. And these were the days, you couldn't do this now because the lawyers would be, you know, on your back.
Switch gears a little bit.
Sure.
I wanted to ask you at all, do you have any involvement at all with the Worcester District Medical Society?
Very little.
Very little.
Mm-hmm.
That's quite a question. Do you have anything that you would like to talk about? Because I know we only have about 5 minutes left. Is there anything that we haven't talked about that you'd really like to share?
I don't want to stand on the soapbox. I would like to encourage young physicians, young people to go into medicine. And please don't forget the patient. And don't hide behind this shield of cost-effective healthcare where you delegate everything to your physician assistant and the triage nurse, etc., etc. Because the patient really feels it, that it isn't quite right. And just be kind to your patients. Just be kind. And if you do that, you don't have to get involved with organized medicine. But if you really want to help people, you've got to do it yourself. And so I don't see anything wrong for somebody who still makes house calls. I did it right to the end, up to my, you know, go to a nursing home, and it's so much quicker. So there is a place in medicine, but what's being done right now, that's wrong. The way it is set up now with these physician extenders, and you call in, I like to get my prescription refilled, and we give you the menu, dial 5. That's bad, and it's so expensive. So I think we have to come off that thing, and it is a fact that if large group practices hire another physician out of his private practice, his or her efficiency goes down and he will work less. And that is one of the reasons why most of the group practices now are in the red. I could give you, so many examples. If somebody's in private practice and he was grossing $220,000, and now he sells out to a large group practice or to the medical school, and now he works for the medical school, his productivity goes down. He will not work as hard as he did. And he will not have his wife in the office or a good woman Friday to be nice to the patient and call him up, etc., etc. And I think that will be a reversal. I'm convinced of it. And this time it's going to be driven by the dollars, by people like the Hunter Group, which is looking over the shoulder of the medical school right now. Because this is... Hunter Group is the group which right now is looking at the deficit of the medical school, since the medical school has a $50 million deficit. And they met yesterday and they made a presentation to the Board of Trustees what should be cut. And they were even suggesting they should cut the heart transplant program and the liver program. That's the Hunter Group out of Texas. And so it's going to be bottom line driven because the money isn't there. And
I think that's a bad thing, but unfortunately, what's another solution?
Well, I was in group practice and they were never in the red, but you work differently. I mean, how did Fallon grow from 5 physicians to 200? Because they did that and just sit there. You work efficiently and you have less of red tape. And so you can run a business differently and still be nice to the patient, but taking totally away the private sector or the individual, I don't think is the answer.
What are your thoughts on socialized medicine?
Please?
What are your thoughts on a form of socialized medicine?
Single payer system?
Yeah.
I would go for it.
Yeah.
Yep. What's wrong with Medicare?
They don't.
Well, but they pay enough. You can make a living getting Medicare reimbursement. And as you probably know, here in Massachusetts, there is no additional billing. It's illegal. You have to accept what Medicare pays. And you know, if you're in private practice, you don't mind the Medicare checks at all. But you don't have that hassle you have with the HMOs or with other insurance companies. So I would opt for a single payment system. And this comes from Rudolph Utzschneider after 35 years, and I'm convinced that's the way to go. The overhead of Medicare, I think, is 3% or 2.5% administrative cost. HMOs, allegedly, the most efficient one are about 8.5%, and they go up to 13 and 14. Aetna and others are probably 17. So how can you beat it?
What's Germany? Is Germany a single payer system or no?
Oh yeah, yeah, and yeah, and everybody is insured. Everybody. It's a disgrace. In 1958, not 59, when I was chief resident, I had my own surgical ward on the 7th floor for the indigent. I mean, everybody was taken care of. There were just no questions asked. If Uncle Willie came in with a gangrenous foot and he needed an amputation, instead of the attending doing it, the chief resident would do it, and the attending would hold retractors. Everybody was taken care of. And there was just no question. You take care of them.
Hopefully we get back to that.
Yeah, I think people have to be taken care of. This is absolutely ridiculous. It's also ridiculous that for a particular drug, you pay in the United States by a factor of 2. You can buy in Canada by a factor of 1. And give me a break. It's, you know.